So we're doing a What's New update. This is the second that we've done in the Baltimore area. We've been doing it across our region, and we're doing it with our partners. It's an overall partnership. And as I mentioned before, this is, for this point, we're calling it the Federal Training Center Collaboration, okay? But it has had many names. And the whole purpose of this was to bring together the federally funded training centers that offer services to populations that we know are being helped by other agencies. So I'm the administrator. My name is Terry Hogan. I'm the administrator for the STD HIV Prevention Training Center at Johns Hopkins. We used to be called the Region 3 Prevention Training Center. However, we've added Georgia and Tennessee to our catchment area, which means that we can't call ourselves Region 3 anymore. I mean, you know, it would be a rather odd-looking Region 3 because we'd have to pull over, you know, go into Tennessee and then come over and pull Georgia over to the East Coast too. So it would be kind of difficult. And we've had meetings every 2 years, and we didn't have one in 2012. And I think that was because of budget problems. But we've had one every 2 years since 2002. Were we in Texas? Okay. If this is Wednesday, it must be Belgium. At any rate, we did one in 2012, and I'm obviously blanking out on Texas. So the idea was that we would start to really collaborate. Now, we were very lucky in Region 3 because we had already started collaborations with the federal, with the AETC and the family planning programs. So we added the ATTC, which is doing substance abuse and mental health. And what I have to say is that what they're doing in the realm of brain work and explaining about addiction and how that has an impact and how mental health very frequently contributes to a person's need for self-medication. And they do that by having unprotected sex and by using substances, all of that, which we don't know about, but they have this wonderful background and all this research that they're doing. So that was a wonderful partnership. So we've been talking about that, and we decided we would all come together and try to talk about how we offer services when we're looking at a patient who might need all of our services. And we don't know how to do certain things, but we can refer. And it's an opportunity for us to network with our training partners and for you, when you come together, to network with folks who are doing other services to probably the same patients that you're seeing. Okay, so that's the overall idea behind the Federal Training Center partnerships that we're putting together. And we wanted also, and this is an example of bringing together all of our resources so that we can offer these kinds of trainings and make them available to you guys without costing you an arm and a leg and what it's going to cost me to get my car back from the garage. But that's, you know, that's the way it is. Timing belts and brakes, very expensive. So at any rate, I'm charged with the responsibility of letting you know that we are going to be taping this today. Not many people will be on, and I want you to know how happy I am to find out that I'm going to be on camera, because I know how svelte I have grown in the past several years. And the fact is that when I don't have a mirror in front of me, I can pretend I'm still 40 years old and I have brown hair. So that's not happening anymore. So at any rate, that's what we're doing. So if anybody has a problem, stay behind the camera. At any rate, we're going to be talking about that. And then what we're going to be doing is thanking all of our training networks that we're working with. So it's the ATTCs. This is the federal government, folks. The ATTCs, the AETCs, the PTCs, and I'm not even doing that. The RTMCCs, that's TB, and the VHNet, which is viral hepatitis. This group used to be, I don't know if folks are aware, it's the Infertility Prevention Project. It's family planning folks who are doing training and outreach, and they've changed their name to make it easier for us. I don't know what we'll call them eventually, but we'll have to. Okay, and these are the federal programs that are sponsoring us, and hopefully will continue to sponsor us even after the sequester. So the CDC has several divisions that are represented here. HRSA, of course, with the AETCs, Office of Population Affairs, the Office of Family Planning, the Office of Public Health Science, which is the HIV/AIDS policy group, and we have SAMHSA, Substance Abuse. So those are our federally funded, federal funding agencies. So they're the ones that make us happen. Okay, we're going to be talking about evaluations. I'm talking about evaluations now because we're all in the process of shifting. We're now getting an electronic registration system, and poor Tanika Smith over here, who is one of our staff, listening to what we're saying, has been charged with the responsibility of trying to make sure that our electronic registration system is working. A couple of glitches, but she's working them out as they happen. So we're going electronic for so many things now, including our evaluations. So we ask everybody to go to the website. You have a paper in your packet that talks about continuing education. We're asking everybody to go to the website to fill out the evaluation, whether you're asking for continuing education or not. Because we do pay attention to what the evaluations say. We use them to try to make the trainings more beneficial to you, that meet your needs. And as you see, here's the alphabet soup of all of the trainings that the continuing education trainings that we offer. You have to pass. I think, how many questions, Jean? Four. There's 4 questions, and are they case studies that are divided up?
I don't think so. It's just different situations with different diseases or issues.
Case studies.
It's not as detailed as I would think of the case.
Okay. So, but at any rate, so there'll be, you have to pass by 70% in order to get your certificate. You get 2 opportunities if you don't pass it the first time. So, it's not rocket science. We're just asking you what you hear today. You go to the website, you fill out the evaluation, and you answer the questions. For addictions, at this point, we are asking you to do paper and pencil. We're asking you at the time that you register, if you want addictions, continuing ed, to let the registration folks know by putting that beside your name. And then Jean was indicating that it probably would be a good idea just to put down whether you want CEUs, CHES, CNEs, or CMEs as well. So that speeds us up for looking at the different types of continuing ed folks want.
And if you have any questions about the different types of credits, you can come see me and let me know, and I can explain them to you if necessary. The other thing is, you have paper evaluations in your folder as well that the ATTC provided. We will be collecting those today, so we're asking you to do both because we're doing unfortunately, different funding agencies need their paperwork, but this will give us a better idea of how to improve the program.
So we're bringing the ATTC into evaluation heaven too. They're going to be using electronic evaluations eventually. We're all going to be doing, we were talking the other day about, not the other day, this morning about cars and how they're getting so smart that we'll be able just to get into them and they'll take us where we need to go and avoid crashes and all that kind of thing, and how everything is being done electronically now. I can't wait to have open heart surgery. At any rate, so these are the kinds of things that we were talking about this morning. We have representatives today from, okay.
So this is the ACRE form from the AETC and then the survey.
Okay. We have representatives here today from the Training Center. We have from the Daniel Institute, which is our ATTC. We have Dorcas Baker, who's here from the AETC. We're very fortunate, and we have 2 local performance sites for the AETC here, one at Johns Hopkins and one at the University of Maryland at the Institute of Human Virology. So we get a lot of expertise. We get access to a lot of faculty. Yes, ma'am.
Terry, we actually serve DC, Delaware, Maryland. We no longer serve New Jersey, but we serve West Virginia, Virginia, and Pennsylvania. As of October 1.
Okay, so now, while we have gotten Georgia and Tennessee and no longer serve Region 3, the ATTC is now serving Region 3.
Right.
So this is the way it goes. And that was Linda Oney. Linda is our rep from the ATTC. And I want these guys to stand up. Jean Hoover, Tanika, Linda, and Shelley's not here, I don't think. Okay. Dorcas, and Abby's not here either because she has another commitment. But these are the folks who did the plan. Where's Dorcas?
She's probably doing registration.
Oh, she's over doing registration. Still doing it. These folks are the ones who put this together. They, yes, give them a round of applause. And don't forget our Tanika in the back, who was handling all the problems when people would say, I didn't get a response, and I registered, and so she would be the one that had to straighten everything out. So I want to make sure we let folks know. And Jean handed me all of this stuff. So this is for the ATTC, which we knew. This is it says what's new. This is the information about going to the website. And then you have this very quick and dirty 1 page. I was making sure there wasn't anything on the back. Evaluation form to do for the Pennsylvania Mid-Atlantic AETC. And then we have a needs assessment. This is what we're doing just to be able to let people know whether this is an effective use of resources. And we ask people to say whether or not they appreciate the opportunity to be in a training session with providers who are from different professions. So if you would fill that out, that was most helpful to us. Okay, so this is still paper and pencil. I'm sorry about that. But that's a good thing because, they're trying to do away with cursive. You can show them that you still know how to do it. So that's a good thing. All right, now I'm going to ask you all to say, who in here, I'm going to ask you just to raise your hand, who in here offers services for HIV-infected persons? Okay, large group. Who in here offers services for individuals who may have other sexually transmitted infections? Pretty good amount. Okay, who in here offers services to folks who have substance problems or mental health issues? The whole class can read their hand. Okay, because we don't know some of the time. And how many folks in here offer services to people who are at risk for, who have tuberculosis? So we have a few folks in here too. How about hepatitis? Okay, so I hope you all were paying attention because when you want to refer somebody, you might want to ask them and say, oops, let's take a look at talking to so-and-so because they work in substance use. Oh, let's talk to so-and-so because they indicated they have knowledge about TB or hepatitis. This is an opportunity for you all to network as well. Okay, so that's an important thing. Family planning, I'm sorry, I forgot family planning. That's only one? Okay, that's better. Okay, we have family planning issues cut across everything. Okay, so when you talk with somebody who's a woman, for example, of childbearing age, and she has substance abuse problems, there's a need for counseling about fertility issues, about whether or not she may need to have some kind of contraceptive services if she doesn't wish to get pregnant. So we want to make sure that we don't miss that opportunity to make sure that she has, if she becomes pregnant, a healthy pregnancy with a good outcome, or if she doesn't want to get pregnant, that we find the most effective contraceptive services for her to help her, especially if she has a substance abuse problem. Because you want to use something so that she doesn't have to remember to take it every day. Unlike the rest of us who always remember to take our medications every day. Okay, so have I covered all the topics here?
The restrooms are in the corner, and if you could put your cell phones to mute or off, that would be great.
Yeah, you'll have an opportunity at break time to talk to somebody. I don't think any of us is carrying the red phone for the president. Okay, good. I just wanted to make sure, because you never know, you know. And I'm going to now turn this over to Jean Hoover, who's going to introduce our first speaker, and we're going to have a great day. Okay, so thank you all for coming, and I'm very happy that we had a half an hour of spring on Tuesday. It's nice that we went right from winter into summer, but we did have a half an hour of spring.
Okay, our next speaker is Kim McClellan. She's a women's health nurse practitioner and the director of women's health at the AIDS Care Group in Chester, Pennsylvania. She's also clinical adjunct faculty at Drexel University. And she's been a women's health nurse practitioner and the director of the Women's Health Services for the AIDS Care Group in Chester, Pennsylvania. And she has done this lecture for us in the past at different locations, and she'll be talking to you today about family planning and preconception counseling.
Okay. Hello, everybody. Good morning. Thank you for coming to hear us speak. Just a little disclaimer. So everything that Jeannie said was true up until a year ago. Oh, really? Okay, wow, okay. I think I'm usually screaming anyway, so I think the mic is scaring me. I'm afraid I'm gonna speak too loud. Just let me know if I'm too loud, too low. Okay, so a year ago, I actually changed positions. I just spent 20 years being the director of women's health at the AIDS Care Group. I'm now full-time at Drexel and also working in the HIV clinic, doing things like PrEP and complex GYN for the partnership clinic at Drexel University in Philadelphia. Same work, just a different address. Yeah. So I usually start my talk by doing what was already done, is just taking a poll of the audience. And I think it's interesting. First of all, I love when we have a lot of HIV folks, and I love when we have a very integrated group. So I think we should have a nice hour and 15 minutes together. But what I want to challenge you to think about is only a few folks raised their hands for family planning. I hope what we accomplish with my talk is that every one of you will raise your hand at the end of my 90 minutes, because I think you'll all find a way that you can become family planning providers after this conversation. Okay. So just a little quick agenda here. We're going to talk today, sorry Jeannie, we're going to talk today about really how we integrate services like what we think of as family planning, but preconception, conception care in the general population, but definitely with the populations that you're all working with, and definitely in the face of HIV. Okay. So every time I give this talk, I marvel at the fact that it doesn't matter how many years I've done this number has not changed. Half of the pregnancies, all the pregnancies in this country are still unplanned. So this is what we're talking about today, is how can we get that to finally switch around. Again, I think this is a low number, but 70% of all HIV positive women report being sexually active. I don't even have to say this, you say it for me. Out of all the folks that are working with HIV positives, do you think that's a low number? Absolutely, that's just who decided to talk about it, okay? And then 25 to 30% of HIV positive women express a desire to conceive. That's actually been shown to be greater, and not just women. We're talking about couples, families. Some both positive, some what we call serodiscordant, where one's positive and one's negative, and we're going to talk a little bit about that as well. Has anyone ever heard the term reproductive life plan? The family planning gentleman in the back, okay, yeah, okay, all right. Well, I think it's interesting because I think once we go through this, you're going to find out you know much more about this than you think. You may just have not heard the term, okay? So reproductive life plan came on the scene many years ago, actually, as just a way for us to gauge the patient's, clients, depending on what kind of work you're doing, what they really think about their reproductive life. And it could be just as simple as asking a question, do you want to have children someday? Okay? Or it can be very, very complex, where you're actually talking about when would you like to have children? If you don't, how would you like to use contraception? When are you planning a pregnancy? But it can be just as simple and just as complex as your population is warranting at the time. It's simply just a plan to when and how to have children, or if you even want to have children. I'm sorry, so the gentleman in the back actually said that he finds that the men that he asked this question are much more surprised than the women. And you know, that doesn't surprise me, because even though last time I checked, you know, it takes a man and a woman, you know, to have a child, but very, very often we overlook the males that we are working with, even though they are a huge part of that scenario, and sometimes really in the driver's seat on how contraception is used within the couple. So I think, you know, it's one of our drives in the family planning movement, and for those of us who are doing reproductive health in HIV communities, is to really get the males more involved in this process. Yeah. So the last thing I do want to say about this is, and one of the points I want to make with all these wonderful comments from you, is that I find, and I would love to hear what you think, but I find when you're asking these questions, you're gathering really crucial information about making a huge emphasis on health, partnering with your clients, and having things like unplanned pregnancies not happen. And we'll talk about all the wonderful reasons we want to have that happen. But we're also doing something that's even possibly more important, I think, is we're empowering the populations we see to take charge of something in their lives that maybe you're the only person that's ever told them they have a chance to do that. You know, we all think, you know, I don't want to get pregnant, I'm going to do this, this, and this. But how many of our populations that have been living with substance abuse, living with mental health issues, living with all the forces of disparity out there, and do you think anyone's ever told them, you actually can take charge of this and not get pregnant if you don't want to? I can tell you, when you work, and family planning folks will probably say this, with teenage girls, it's amazing to me that they don't think that they have that power. You know, even with all the messages and all the wonderful programs we have out there, and you know, and all the wonderful counselors we have out there, if you tell a 13 or 14-year-old girl that she doesn't have to get pregnant this year if she doesn't want to, they're very surprised. Or not only are they surprised, they have no idea how to make that happen. So I think, you know, take that scenario of the teenage girl and apply it to the populations of disparity that you're working with, and you probably are the first time anyone's ever asked them or empowered them to think of this. You know, it's the release of this sense of fatalism. Life doesn't have to happen to you. You can actually make life happen another way. Okay, so no matter who you're working with, reproductive life planning should be addressed with anyone that has the ability to reproduce. So man, woman, of reproductive age, women, until they stop menstruating for a whole year, still have the ability to reproduce. Men, almost for their entire lives, okay? Okay. So we have to remember that, you know, because we think that people, they turn 65 and they no longer have sex, and we know that that's not true. They also get STDs, they also get HIV, they also use drugs. We all know this, right? So you want to maintain a fluid response too, because doesn't the face of the lives of our clients change? Someone who's actively using and then isn't, you know, someone who has untreated mental illness and then is treated, someone with HIV or AIDS is very ill, gets treatment, starts doing much better. So our clients' lives are fluid, so this has to be fluid as well. Okay. So family planning folks, this might be old news to you, but it might be a good review plus some information for the rest of us, is when we look at what types of contraception are out there. So contraception is a fancy word for birth control, okay? And it doesn't have to be hormonal, and it doesn't even have to be pharmacologic, okay? But any method you're going to use to stop a pregnancy, which is usually stopping ovulation, or at least stopping, go back to the birds and bees, the sperm from fertilizing the egg, right? So we look at a tier system, and this is adopted from the World Health Organization, and we're looking at what is most effective in preventing unplanned pregnancies in a year by the amount of users that have used this method. So tier 1, the most effective. They're what we usually call LARCs, okay? So it's long-acting reversible contraception. This is what we're really trying to move to. For patients of ours that would like to use these methods, they have the greatest efficacy, the greatest chance of stopping an unwanted pregnancy, and they're still reversible. So things like the Nexplanon or Implanon, which is an implant, progestin implant that just sits in the upper arm, an IUD that would sit in the uterus. Some IUDs are hormonal and some are not, so we'll talk a little bit about that. And they're really what we call the LARCs. Then there's, of course, there is tubal ligation, like female sterilization, and male vasectomy. Those are not reversible for the most part, okay? Or for people who want it, we hope it's not anyway. Okay. So then we move to tier 2, and there are things like Depo-Provera, like the gentleman in the hat is giving people out there on the street in Baltimore, right? So Depo-Provera, or lactating, so women who breastfeed, that actually slows the start of ovulation. Most of our, we champion the fact that most breastfeeding women in this country, HIV positive, we ask them to not do that. Other places on the globe, they do. Okay. Oral contraceptives, which are pills, the patch, and then the vaginal ring. These are all in tier 2. Okay. Still effective, not quite as effective as those tier 1. And then we have tier 3 male condoms, diaphragms, female condoms, and fertility awareness methods. And then all the way down at the bottom, withdrawal, I always think that's the strangest picture, the withdrawal picture, and spermicides, okay? So just taking a look at this tier system, do you see any trends? Like, what's the biggest difference between the tier 1 stuff and things that fall below it? Do you see a trend? Do you see any commonality? Tier 1, it's not necessarily that the method is better. It's not necessarily, because many times it's the same pharmacokinetics agent. It's the same medication or hormone. It's that there's no human factor in it, okay? So injectables, Depo's still a little more effective than having to take a pill every day, because you do come in, you administer it by a clinician every 12 weeks, but you could still decide to not show up, okay? You have to take a pill every day. You have to put a patch on every week. You have to put a vaginal ring in once, every 3 weeks. Of course, we can talk about condoms and female condoms and how they have difficulties. But the only difference really is that the human behavioral factor is taken out of the equation. Okay, so did everyone hear her question? No? Okay, it's a very good question and a very good comment. So for younger women who are maybe 21 or below, and seeking to have something permanent like a tubal ligation, because maybe they've started having children at 13, 14, and they already have children, they know they don't want to have any more, but there's a big drive, and we'll talk about whether that's right or wrong, to the best of our moral ability, right? To talk about whether or not there is a pushback to get that done if the young woman is saying she indeed wants it done. So a couple comments I have about that is, and that's one of the best reasons to really consider the LARCs, okay? So I'm thinking that this young woman who wants to have a tubal ligation, she wants to make sure at that moment in time she does not have another pregnancy, okay? So that's why tubals are very, they're very shiny, they're very out there. We want to grab it because we know that it's the most definite thing of what we have in our arsenal. But with the advent of things like implants, IUDs, things that have very high effective rates, but can be removed. Also, long-term effective rates. So the IUD can stay in for 10 years, 5 years, depending on what kind you have. The Nexplanon can stay in, the implants can either stay in for 5 years or 3 years, depending on which one you have. So we know that they have high effective rates. You can just put something in, put another one in when it expires, and it's going to be just as effective, most likely, as the tubal ligation. But what you have is you do have the ability to not permanently sterilize a young woman. So you kind of pull out of the mix your moral judgment as a provider, because I would never want to sit and tell, I don't care how young she is, I don't want to sit and have that moral judgment on any young woman who is telling me she doesn't want to have a baby. Because you don't want to belittle that young girl that has trusted you, brought you into her fold, and confided in you this. Because you don't want to say, oh, you don't know what you're going to want when you're 25. Now that might be so, but you don't want to say that. But what you can offer her, because you have to offer choices, you can offer her something like an implant or an IUD that is going to protect her for anywhere from 3 to 10 years, or maybe even longer. Okay. The reason I say that is because research has shown, and there has been now a body of research developed qualitatively on what happens when young girls decide to use a permanent option, and the regret factor is what they call it, okay? So there is, on the other side of that, severe depression and a manifestation of everything that involves for these young women who, when they were 17 or 18, felt they no longer wanted to have children, and now they're 26, 28, they have maybe the same or another stable relationship, and now they want to have children. And that the backlash of that regret has been an issue, and it's starting to get well documented. So what's the take-home message here? You have a young girl who doesn't want to get pregnant. That may or may not change. So do you want to do something at that age that is permanent, or do you want to choose something that is just as effective, can continue, and if she never wants to have another child, she doesn't have to, but at least you're controlling the controllables. So you're stopping that permanent situation from happening, and the research is starting to show that that might be a better option. Okay. Any questions or comments about that? Yes?
The only thing I think about is every commercial, especially for the IUD things, is they run through this long list of possible side effects, including death, so on and so forth. Where
Death, nuclear war, yeah, everything.
yeah.
Yeah.
So even though I appreciate and agree with everything you've said, I worry about that. And the implant, I don't know that much about that, but I do see the advertisements for IUDs a lot.
Yeah, and I think if, and that's where, really having us get out there and have very evidence-based information and education to our clients is worth so much. Because we could watch television and think that anything is going to kill us. And some of it is very founded. So when you see those messages about IUDs, about the progestins, about birth control, about hormones, about anything, the farm industry has to tell us any side effect that could possibly happen. But aspirin has tragic side effects. Anything can have a side effect profile, but that's where you have to get the right information out, and you have to make sure that individuals that really shouldn't use an option are educated on why they shouldn't. The point is we have so many options that if this over here, A, doesn't work for you, you have B, C, and D. But then there's also information out there that is very false, And we have to remember, most of the issues, now I'm not talking about the IUD issues, we can talk a little more about that. A lot of that is historical and not necessarily real day, and the hype, and we're starting to get past that a little bit, because IUD use is actually on the rise in the US with young women, which is good news with the new IUDs that we have. But most of the issues when you talk about side effects of contraceptives, which are hormonal, is usually issues with exactly that, high levels of estrogen, high levels of progestin. Do you know what else causes a lot of issues with our healthcare because of high levels of hormones? Family planning folks, if you know this, you're not allowed to answer. Okay? So another condition of life that causes high levels of hormones is pregnancy. So all of the different, we hear about all of these issues with blood clots and pulmonary embolism and stroke and a lot of cardiac issues with the use of estrogen in some of these products. Pregnancy carries all those same, maybe not quite the same, but definitely pregnancy causes all of these hyperestrogenic effects that estrogen pills do as well. Okay? So pregnancy is an issue. So preventing pregnancy, you know, we're going to talk a little bit more about that, but it's not necessarily a reason not to use this or to prevent pregnancy. Okay? For those of you that are working, well, everyone's working with clients and patients, but even if you're not in family planning, do you happen to know what types of methods of contraception the people you're working with might be using? I know you have Depo, right? So what I can tell you that tends to happen in my old practice, and there's a little difference into the new practice I've just started to work in, is the hands down biggest option was condoms, only condoms. We talk a little bit about that. That's coming from an HIV perspective. Second would be Depo-Provera. And it really worked rather well for the patients' lives that I was working with, because they would have to come in and see me for primary HIV care every 3 months for blood work, and the Depo shot was given every 12 weeks. So it was something that they knew they could rely on, something that worked very well for their lives. And for the most part, they came in like clockwork. Didn't have a lot of pill takers. Most of my patients are already taking less pills than they used to have to, but still having to take pills every day. They just didn't want another one. Never was able to get anyone to want an IUD, although I would like to. Now, the new practice I'm in, they use a lot of implants and a lot of IUDs. But really, that's what I was using most. IUD, I mentioned this, is actually increasing use in young women. And there's a brand new IUD, if I know the family planning folks probably know even more about this than I do, is the Skyla, which is an option for the Mirena. It's just a progestin agent. They're really marketing that to young women. It's, believe it or not, even smaller. Is anyone in family planning, have you put a Skyla in someone yet? Okay, yeah, I mean, I saw one, and believe it or not, it's smaller than the Mirena, but they're already so small anyway. But it's being marketed for young women who have not had children. Okay. Sterilization is still biggest national way of preventing pregnancy. Okay, so we're going to talk a little bit, and I think Jeannie was going to put in your packets a copy of this chart. Okay, if for some reason you don't have it, or if you want to get another one, you can actually get laminated copies of this from the CDC website for free. But it's really nice to keep in your clinics, or even if you're not doing family planning, keep it there, because you can talk to your patients or your clients about it. We've always used in family planning, until 2010 when this came on the scene, the World Health Organization's eligibility chart. It was kind of our Bible that we went to, is if you have a patient who wants this and they have this, is it okay to put them on it, okay? 2010, the CDC, many folks from the World Health Organization and other expert panelists from the nation put together our first ever US specific list, eligibility criteria for contraception. It really helped us, because there's, not that they weren't wonderful, because they were, but many times those of us working in the US would look to the World Health Organization's chart. A lot of it didn't have anything to do with what was happening in the US. It was a very global perspective. So I don't have any patients that do this, but if you had a patient who wanted to have bariatric surgery, there was nothing about that on the global perspective from World Health Organization. My patients don't do that. They wouldn't have the money and they wouldn't have the insurance to do it. But that's just an example. So it allowed us to really make this much more US specific. Very easy to read as well. It is literally just like, what do we think green means? Go. What do we think red means? Just as easy as that. And then there's the categories in the middle. So green 1 means there's no restriction. Use it, you're fine. Of course, the opposite, 4, which is red, unacceptable risk to use that for whatever's happening with your patient. No. So 2, a little lighter green, is usually the benefits would outweigh the risk of using that. And then 3 is usually the risk outweigh the benefits. So the ones in the middle are not absolute contraindications, but it would give you a little more cause for cause for looking a little further into it. Okay, and it's actually broken up, you can see it, into, if your patient has this, and you want to use this, or method, is it a red, is it a green? Okay, so just want to draw attention because many of us are working with populations that have these conditions. So according to this eligibility criteria list, some of the conditions that are associated with an increased risk of a health event if they have an unintended pregnancy, so breast cancer, complicated valve disease, diabetes, all the things we think of, high blood pressure. What else is on there is HIV and AIDS. Tuberculosis is on there. Okay, so these are all conditions that if the patients or the populations you're working with, you would want to consider using some of those more efficacious or those higher tier or those LARCs, because these are populations of patients you really don't want to have an unintended pregnancy. You want to plan it out, you want to make it as safe as possible. Not that they can't have the pregnancy. Do you ever think we can ever tell people they can't have something? No, okay. I love that because this is always preaching to the choir here. You guys know that. You know, you're not going to sit there and tell a patient, no matter how much you think it would benefit them, that they can't do something. It's kind of like having teenagers. The opposite is going to happen. And we don't, nor should we ever want that kind of control in someone's life. You want to empower somebody, not tell them what they can and can't do. But many providers, unfortunately, think they have that power. They think if you tell someone you should not get pregnant just because I say so, that's going to work. And we're fooling ourselves. So what we need to do is, in a much healthier, therapeutic way, ask someone what they think, reproductive planning, right? Ask them, what do you think about having a child? If they say, I don't want one, then you go down that road. That's an algorithm. You go down that road on how we can safely prevent pregnancy for you. Or if they say, even if you feel it might not be the safest time, I would like to have a baby now, or I'd like to have a baby in a year. Then you can open up that conversation about how we can plan that out safely. Okay? But these are definitely conditions that you don't want to have unintended pregnancies happen. Okay. All right. So I'm going to just take a little bit of time now to talk about each of the different methods and how they relate when you're working with someone with HIV. Okay? But many of these issues, and I want you to stop and ask me a question if you have it, many of these are not just HIV specific. It could really adopt to many of the populations you're working with. So oral contraceptives, so pills, whether they are both hormones, so every birth control method that has hormones either has estrogen and progestin in it or just progestin. That's how the hormonal preparations work. But there are some that have no hormones in it, and we're going to talk about them too. But oral contraceptives, whether they are both hormones or just one, same criteria in use on someone who's HIV positive or negative. Okay? The HIV disease itself, and we'll talk a little more about some of the other bodies of knowledge that are coming out about how HIV either does or does not progress with hormones, or whether people can transmit more or acquire HIV more with hormones. That's a separate topic, but we'll talk about it a little bit at the end. But what we know is, and what the CDC, the World Health Organization, say is that there should be no restriction for HIV positive individuals that want hormonal contraception because of their HIV. And that's not only birth control pills, that's everything that we're going to talk about. That goes against what a lot of us have learned. You know, I know when I was first becoming a women's health MP, you know, we thought maybe we had to worry about IUDs in HIV positive women. We know that that's not the case now, and the guidelines support that. Okay. What we do worry about, though, is sometimes we worry about how the medications that we're giving people to treat their HIV could interact with the hormones. Now, in only one instance with one particular medication that we don't use as much now, most of the time it is not a problem. The hormones don't cause a problem with the HIV medications. Usually what happens is some of the HIV medications, especially the protease inhibitor class that's boosted, can cause a problem with how much the estrogen in the pills or preparation work, okay? So again, just to repeat that, sometimes it gets complicated, and I might make it more complicated than it needs to be. But HIV medications, except for one particular one, no problem, you're not gonna mess up someone's HIV regimen by giving them hormones, okay? However, the other does work, where if someone's taking a boosted protease inhibitor, sometimes their estrogen in their birth control might not work as well. And if it's not working as well, then someone could ovulate, that could maybe be stopped, that mechanism of the estrogen, and then someone could become pregnant when they won't want to. So family planning folks, you can answer this, okay? So if we are giving someone, not just HIV, we're giving someone a medicine, because other medicines, not just HIV medicines, can lower the effect of estrogen, okay? So if we're giving someone an antibiotic, because let's say they have strep throat, and we worry, or even better for this room, we give them a medication for tuberculosis, okay? Even better. And we worry about whether the estrogen is going to work as well. What do we tell them to do? Right. Someone has HIV and they want to have sex, and they've talked to us about it. What are we going to tell them to do? Someone doesn't have HIV, they're having sex. What are you going to tell them to do? Right, so get the message. No matter what, we're telling people to use condoms, okay? So do you think that that's a reason to withhold hormonal contraception for someone? No, okay? You're just getting the dual benefit, because we know condoms aren't perfect. And why aren't condoms perfect? Right, because condoms actually are very effective if they're used perfectly. How many people use anything perfectly, right? So, yeah, so you're going to use that backup anyway. You're going to get that message out to people anyway. So why not use the dual protection, which is what we always educate our HIV positive couples to do, but it's what we should be educating everybody about. Okay. Just a couple words about the patch, and really the patch and the ring, pretty similar, okay? Both can be used with HIV. This has not been completely documented in evidence-based practice, but we know that clinically, it appears that possibly these levels of these hormones in the patch, in the ring, may actually not be as affected by the HIV medicines as some of the other preparations. The reasons why is we don't have to take this in a pill, okay? It doesn't have to go through our liver to be metabolized. This is released in another way. So because it escapes the liver's metabolism mechanism, we think it may have higher levels, achieve higher levels of estrogen and progestin in the body, not as affected by some of the HIV medications, okay? I would like to say that to all my patients and have them do it. Almost none of my patients want to use these, okay? They either want to use Depo, some a pill, or some just condoms, okay? But I know, I think it was you, ma'am, who said that a lot of the young girls love the patch. Yeah, well, I mean, that's been my, in a non-HIV clinic, that's been my experience, but yeah. But I haven't been able to get too many of my patients to use it. One caveat to that is you really need to watch. Someone should be less than 90 kilos for that to work well. It's just the delivery system. It doesn't work as well if someone is heavier than 90 kilograms. Okay. Side effects, many of this is because of the estrogen. Not that much different than the side effects we see from a birth control pill that has estrogen. So with any hormones, you can have changes in vaginal bleeding and menses. You can have nausea, vomiting, breast tenderness. But to get to your point, ma'am, about the side effects, not often, but because this sometimes happens, you have to list it, okay? Okay, the combined vaginal ring, so just as you get the estrogen and the progestin through the skin, through a transdermal patch, you can get this delivered vaginally. Again, goes past the liver, that first pass effect, maybe has higher concentrations and effectiveness even with our medication. Prevents ovulation, that's how all these mechanisms work. Okay. same side effect profile as the patch. The only difference is some women, and you'll have women come in and they say, I think I have an infection. I think I have a yeast infection. I think I have a bacterial infection. I have a lot of discharge. And then we put that under the microscope, we take a look, and it's actually not any type of infection. What it is, it's just this healthy increase in white blood cells in the vaginal vault. And that's the same thing that happens in pregnancy, because you just have this influx of estrogen in the vagina, and it causes the lactobacilli, which are our friends. They keep our vaginal vault healthy, and you can just have this healthy increase in vaginal secretions like a pregnant woman has. Okay, but you may have patients who get worried about that. All right, so DEPO, we spoke a lot about DEPO already, but it's given every, you could give it anywhere from 11 to 13 weeks. Even people think it probably even works out a little further than that. 97% effective if used correctly. Okay, and then the contraceptive implants. Again, there's the Nexplanon and the Implanon. Biggest issue with that, and I've had a few patients who have not been happy with it, because there is a high incidence of having really irregular menses with that and a lot of vaginal spotting. Have you guys seen a lot of that, family planning folks? Why are the family planning folks in the back? You're all clustered in the back there. Okay, that's interesting, yeah. And I mean, what I've heard from patients is that with a lot of the, as you mentioned, sir, with a lot of these hormonal preparations, you can, anytime you change someone through hormonal preparations, you're gonna have a period of some irregularity. And different patients are more tolerant or less tolerant of that, depending. But what I've heard from patients who, if they've had this irregular bleeding, not quite like the other methods, it tends to stay as long as you have the implant. Yeah, where some of these you can kind of counsel patients through, and you can say, well, that's, yeah, that's going to be the first couple cycles, but then it'll get a little better. Many times when patients have this side effect with the implant, it stays the entire time they have it. Yeah. Have I tried cyclodextrin pills? I've actually only had like 2 people now. Myself now, my new practice has a lot of people on the implant, and they actually don't care, about it. So no, we haven't introduced pills to that, because our patients already really just don't want to take them. But I'm working in an HIV clinic, so that might be a little different. The tolerance may be different. But yeah, I just have a lot of patients who are intolerable to changes in their menses. It's actually the biggest complaint. Again, DEPO I use a lot, but the biggest complaint I have with DEPO and why people switch if they decide to is many of us like the fact that DEPO usually makes you lose your menses, okay? And different women can have different effects, but that tends to happen quite often is someone on DEPO, they'll stop menstruating. My patients, especially my patients who come from West Africa or the Caribbean, which I have a large population of that, they are very intolerant to changes in their menstrual cycle. So they don't like that they don't get their period. Now to some of us American women, that sounds strange. Some of us, they love that. But they're very intolerant to losing their menses. So again, the message is you just have to figure out what your patients like, and they're going to be much more adherent and much more happy. Okay. So then the IUDs. There's no known drug interactions from the HIV side with the IUDs. There's actually 3 types of IUDs, but 2 modalities of how they work. So we have the copper or the copper T or the Paragard, no hormones. The reason it works is because it causes this chronic inflammatory process in the uterine lining that really slows down the chance of ovulation, makes the environment inhospitable to having a pregnancy happen. That's how that works. Where the Mirena, but now we also have the Skyla, which is just a progestin agent. The Mirena is actually approved also to treat women who have heavy menses, or what we call menorrhagia. Okay? So many women, not everyone, not quite like the DEPO, but many women will actually have a dramatic decrease in their menstrual bleeding when they're on the Mirena. So I spoke a little bit about how we used to believe that IUDs, we used to believe IUDs weren't good for adolescents either. Okay, now we know that that's not true. But we now know that IUDs are absolutely fine, not contraindicated because someone has HIV. But as far as eligibility criteria using that 1 through 4 system, you can see almost everything is a 2. The only reason, and 2 meaning, of course, the benefit outweighs the risk. This is using these 2 types of IUDs in an HIV positive woman. So using it, just initiating it, that means putting it in someone who's HIV positive, a 2. The benefit outweighs the risk. Continuing it, benefit outweighs the risk. Same for both types. The only thing that pops up to a 3 is if someone has a true AIDS-defining condition. Okay, so we're worried about them being immunosuppressed. So if they have a true AIDS-defining condition and you're initiating the IUD, whether it's the Paragard, the copper, or the Mirena, the progestin, then you may want to think it moves to a 3, not a 4, but it moves to a 3, meaning that you would want to potentially outweigh whether the risk is higher than the benefit just because she's immunosuppressed. So again, not a reason to not put it in, but you may want to think about starting her on treatment, getting her immune system a little higher, only because of the possible increased risk of PID. Okay? But every woman that we initiate an IUD in, we watch for that anyway. Right? So, and if someone has an IUD in place and they become AIDS defined, it doesn't change, it's still a 2. You're just going to monitor these women. It is better to put an IUD in if that's the only thing she's willing to use than to have her get pregnant. Okay, that's the risk versus benefit. Any questions about that? No? Usually someone says, I thought we couldn't use IUDs. You guys are smarter than that. Okay, all right. So just to drive the point home, there's no higher risk in an HIV positive woman over an uninfected woman for any complications or infections. IUD use not associated with increased risk of transmission to sexual partners. And a woman with an IUD in place who develops AIDS should just simply be monitored like any other woman for a higher reproductive tract infection like a PID. Okay, so we can go through the, yes?
One thing that we are seeing in Baltimore City is a lot of docs don't want to put in an IUD right after birth because they're talking about the expulsion rate. So I'm curious to hear from you what you think about that, because what's happening is women have requested it and you have that opportunity with them in the hospital and they end up with nothing, and then we see them pregnant again when they've asked for an IUD, but the doctor believes that if they put it in, there's a high expulsion rate.
Right. Oh, that's a great, I'd love to comment on that. Right. Yeah, so the comment from the gentleman in the back was that there is a thought process that possibly the fact that the uterus responding to very high levels of progestin right before delivery could be softer, there could be a more risk of an invasion into the uterine cavity with an IUD. Okay? So what I can tell you is there are different providers who feel differently about this. The push really has started to allow for us to do things like that, like put it in right at delivery. Our practice, we do that. We put it in right, if the woman wants an IUD, we put it in at delivery. When I've questioned other providers on really why they don't want to do that, there is answers just like the gentleman in the back, which absolutely has scientific basis, okay? But oftentimes, you also get down to where it becomes an insurance issue. Now, we have the absolute wonderful benefit that not everybody has of being not only a Ryan White funded HIV clinic, but we are also a Title X family planning entity. So we have ability to have IUDs there. So I completely understand, because where I come from, we didn't. Okay, so I understand what you're up against there. But we have been doing this for several years. The guidelines now, and actually they just came out in 2012, an update to this criteria, do support the administration or the initiation of IUDs at time of delivery. They support that now. That has started to change some of the providers' beliefs. ACOG also usually follows, this is what the OBGYNs follow too. That's their Bible, is ACOG. So ACOG has gotten behind this practice as well. I can just tell you clinically that we don't see this mass amount of expulsions. And we don't see women coming in with adhesions or interruption in their uterine cavity because it's been put in. Absolutely, you have to worry about a uterus that's been exposed to high levels of progestin, but that's where you're weighing the risk versus benefit, because do you want that person to come back to you at your 6-week postpartum? This is our nightmare that happens, and she's pregnant, because that's not good either. Yeah, so that's where you're weighing the risk versus benefit. Yeah, and that is one of the best things that we can do. Because I'm a provider, I'm a women's health MP, I'm a family MP, I see patients, I'm not a surgeon, okay? So, so I can't be the one that's actually putting it in. I'm lucky to work beside someone who embraces that practice. But I also understand where the reluctance comes in, and quite honestly, until this summer, the guidelines didn't support it. Okay, we had a lot of people who were doing it anyway because anecdotally we thought it made sense. But the guidelines didn't support it. It's a new finding. I think as we start to educate our patients, as just to ask the questions, as we start to see people like ACOG entities, like institutions and agencies like that embracing this, it will trickle down. I mean, if you told me now I was going to be standing here telling you all this stuff 20 years ago, I would think that's not going to happen. I was seeing HIV patients in hospice because we didn't have all this. Okay, so things change, things evolve, and I think it's a very positive trend we're on. But you're doing the best thing you can do. You're having that question asked because then it comes up. Okay. So just really quickly, especially for the HIV folks and the family planning folks out there, but anyone who's working with someone who's on medications for their HIV, just to drive the point home that there's really not an issue between the medications. So class-wise, so when we're talking about the class of the non-nucleosides that we give, so a lot of people know the 1 pill once a day, okay? So it's Atripla, okay, but there's others as well. So again, there's not a protease inhibitor in that complement. So we don't worry as much about the effectiveness of what's going to happen with the HIV medication and the ethyl and estradiol. So you have patients on that, not as much a concern. However, we do worry a little bit, and for anyone who's had the opportunity to work with patients and have them learn and use emergency contraception, has anyone had that? And how about the news that now that young women can get that without prescription? That's kind of new and wonderful. Okay, so so we worry just a little bit, but not enough again to not use it. We still think the benefit outweighs the risk. But what some of these non-nucleosides do is the opposite of the protease, is they can make the progestin in these medications not be as bioavailable. So when we use Plan B, whether it's the 1-step or the 2, it's only progestin. So you have to keep that in mind if you have somebody that's on a non-nucleoside regimen. Sometimes you have to know that maybe their emergency contraception won't work quite as well. Still, you should do it. There's no reason not to. Okay? And again, this is an example of all the protease inhibitors, most of which we boost with, if you guys have heard the term ritonavir, so we make the protease inhibitor a little more bioavailable. It does decrease the estrogen, but what are we going to do? Tell them to use condoms, right? It's not going to change anything. The only caveat to that is if anyone has heard the drug atazanavir, or it's also called Reataz, every once in a while you'll have someone that's still using that, not with ritonavir, it's not boosted. We don't do it too often, but atazanavir can actually do the opposite of everything else. It can increase the estrogen. So that's the one protease inhibitor that if you're not boosting it, you don't want to use some of the higher estrogen component regimens, because then you'll have someone have a little more estrogen than you want them to have. Okay. Some of the newer classes, like the CCR5s, no dose adjustment, no problems. Okay. So about 18, now it's like 24 months ago. And just at CROI, if anyone's ever heard of CROI, which is a big conference that we have on retroviruses, just happened in March in Atlanta. They talked about this again. There was a study that was published a couple years ago and came out about 18 to 24 months ago talking about whether we should be using Depo-Provera in HIV-positive women. Has anybody heard of that issue? If you have, just raise your hand. No? Okay, so it might be a non-issue then. So sometimes I'll come before some folks who say, I thought you weren't supposed to use Depo in HIV-positive women or anyone at risk because they'll get HIV more readily, or they'll give HIV more readily. So there was a host of studies, and then those studies put a little question in our mind about this, sparked more studies to be looked at, retrospective study, most done in sub-Saharan Africa, where almost everyone uses Depo-Provera, because that's what's available there. Okay. And the question or the concern was, out of this one study, is that possibly women who are at risk for HIV and they're using Depo, possibly they could get HIV from their partners more readily. And then the other was true, is they were concerned on whether, if that's true, could those HIV-positive women using Depo, could the mechanism work the other way where they can give HIV, transmit HIV more readily to their partners? Out of a host of studies caused a panic because many of us use Depo, and many in the US use Depo, but even more so globally, because that's what's effective there, and there's even more reason, a host of reasons to prevent unplanned pregnancy in other third world countries. Looked at very critically, looked at again this year at CROI, and the recommendation has not changed from the World Health Organization that there is no convincing evidence that using Depo-Provera can increase a transmission risk from a positive woman to a male. The only question is, could there possibly, from this one study, be convincing evidence that maybe an HIV-negative woman at risk, because of the Depo, could acquire HIV more readily? Absolutely not the other way, but because there is still this question and we need more studies, our responsible practice needs to include, what do you guys think? Condom, right? Every time we do that, that means condoms. That's the answer. That's the universal language for condoms, right? So what we're going to do is we are going to take that information. We are not going to stop women from using Depo. There's not enough evidence for that. And if that's the only thing they're going to prevent pregnancy, we're going to have her use that Depo, because what else causes an increased risk? We know pregnancy causes an increased risk of transmission and acquisition of HIV. We know that. That's documented. All because of the same mechanism. Depo causes a low estrogenic state in the vaginal vault and in the cervix and in all the tissues of the reproductive tract of a woman. Okay? Thinking that if it's a hypoestrogenic state, same thing that happens after menopause. Women who are postmenopausal have an increased risk of getting bacterial infections of the vagina, increased risk of acquiring STDs, and increased risk of acquiring HIV because they don't have enough estrogen. That's what happens after menopause. Depo-Provera causes the same environment, and we worry about their vaginal tissues possibly being more readily accepting of infections, bacteria, and viruses. Also, high progestin state is pregnancy. So all these things can cause the same issues, but we do know that Depo stops pregnancy. Okay. So again, the message is the same, not a reason, and the World Health Organization backs it up, is that you just teach these women to use condoms. Okay. We spoke about how if you use condoms perfectly, they're great. Okay. Dual contraceptive use. Okay. These is just a few tools that are out there. I had the great opportunity to be involved with this group from the CDC. Is that we were looking at ways, all these wonderful messages that I'm talking about, how does it get done when you're in a busy clinic or a busy provider's office and you're seeing 1 million people in a day? So what we're trying to do is really provide tools that are very simple to use. Does the couple want pregnancy? Yes, you go this way. No, you go that way. Okay? And these are all available on the CDC website. Okay. And these are just showing that there's actually people that say what I say is correct. Okay? So these are the DHHS guidelines that talk about how important it is to do preconception counseling with couples that are living with HIV. Okay? Important. You know, on the other side, we talked a lot about couples who do not want to become pregnant, but what about those who do? Okay? So I mentioned a little bit on how it's a wonderful time if someone tells you they want to get pregnant, but maybe they haven't had any HIV treatment, maybe their CD4 count is rather low, their viral load is rather high. It's a great time to have the conversation. It's great that you felt you could tell me you want to become pregnant. Let's talk a little bit how we can get you ready for that. Not any different, thank you, not any different than what we tell any woman that wants to become pregnant. If we actually have patients who feel comfortable with us enough, we're not one more person that's telling them that they have no business having a child. Because I have a lot of patients still in this day and age who have HIV who might be 20 years old, 25 years old, and they've been told they have an HIV diagnosis, and then they're told next you should never have a child. Now to me that's astounding with everything that we know. I would never tell a diabetic woman she shouldn't have a baby. I'd rather take care of an HIV positive woman pregnant than a diabetic any day. Much simpler. Much easier to control HIV than erratic sugars in pregnancy. Okay? So we know that we have the ability to reduce transmission to the baby, less than 2%, if we follow this protocol. But guess what? We can't follow the protocol if we don't give our patients the opportunity to talk to us about it, to embrace their treatment. In my experience, there is no more of an adherent patient in this world than a pregnant woman, okay? Or a woman who really wants to have a baby. You want to talk about someone really driven with a mission to take her medicines every day. That's the group that I love to work with. Okay, you can also get this from the, thank you, AETC, okay? So you can get this also from the website. These slides are great, talking about some of the perinatal guidelines, some of the stronger recommendations, and how they looked at it. Okay, this just backs up everything I said. I'm surprised this question hasn't been asked yet. Okay, so anybody working with HIV positive couples where one's positive, one negative, discordant, who want to have a child? Have you ever had to have that conversation with anyone? Yes? I'm going to come to your clinic. You're seeing everybody. Yeah. All of these issues, HIV is usually the least pressing issue in many of our clients' lives. And I say that I work in an HIV clinic. So I can't imagine from the different types of practices that you're coming from, this is not necessarily on the radar of the patients that you're working with. But I think our question is should it be? Okay? And maybe that first time you meet that person in a crisis, or that first time you're sending someone to detox, or the first time they come in and they say, actually, you know, I want to start taking these medicines because things are just crazy in my head. That may not be the time that they tell you, hey, you know, I want to have a baby in 5 years. You know, that's not going to happen. That's unrealistic. But they will remember that you asked the question. And then maybe a year from now, maybe 6 months from now, maybe 5 years from now, somebody will come back and say, hey, you asked me that. I think I want to do that now. And I used to hear people say that, and I thought they were crazy, but it happens. When you don't think someone's hearing what you're saying, they actually are. Okay? And you're giving them the ability to come back and ask you. So just a couple words, because I want to leave time for questions. A couple words about working with serodiscordant couples who want to plan pregnancies. We actually have the ability at the practice I'm now to start to implement something that we call PrEP. And PrEP stands for pre-exposure prophylaxis. Now, we've been doing counseling with these couples long before we decided that we were going to start to give medications for PrEP. However, you know, there's always different scenarios and there's always a risk factor. So anytime someone decides that they are going to have either unprotected sex or have some kind of an issue as far as becoming pregnant where one person's negative or positive, nothing is 100%. But every year, more bodies of research present itself that allow us to make the decision a little easier, a little more responsible, and a little bit more protected. So really quickly, the easiest scenario is when the woman is positive and the male is negative. You guys know that there is no HIV in sperm. HIV is in semen, right? And you need the vehicle. The guys need something to swim in, right, to get where they're getting, okay? But that's why sperm washing works, okay? But sperm washing, the cheapest I've ever been able to find it, I'd love to hear if anyone else found it cheaper, $1,200, okay? And that's just for the process of sperm washing, because if you take the semen away, you still have to somehow get that sperm to the egg. Okay, so then you're talking about fertility practice, you're talking about in vitro procedures, very expensive. My patients can't afford that. And I'm thinking from where you guys are coming from, it's the same. Okay? However, what we can do, and it's been very based in evidence practice and the research and the body of research that we have, is that if we get the positive person's viral loads maximally suppressed, they have a very low likelihood of transmitting the disease. Now, we have to be really careful with that, though, because we never want to tell our patients that anything is 100%. Okay? But we say, if you want to incur this risk, and let me tell you what the evidence says about what your risk is, here's where you can be the safest you can possibly be. Okay? And we know that if we get a woman before delivery, viral load less than 1,000 copies, but better even to have it maximally suppressed. She's on medications while she's pregnant. She's on medications while she's delivering, although there's a little new controversy about that. And then the baby takes AZT, unless the baby needs more than one med, but usually one med, AZT for 6 weeks, doesn't breastfeed, there's a less than 2% chance. Okay? All right. So I want to, there's so much more here, but I want to stop and make sure that we answer any questions. And I also just want to make sure you know that at the end of your packet there is these great hotlines out of the University of San Francisco. Yes. That you can call providers, patients, anybody. I've called and I've gotten great answers from them. Yeah, well, so the question was more about how do we use the medications in a pre-exposure, post-exposure kind of scenario with someone who's a male who's negative, female's positive. Well, actually, patients do what they do, okay? But I would actually advocate for a scenario like that there really doesn't have to be unprotected sex, okay? So if the female's positive and the male's negative, all you have to do is get that confirmed, though. Confirm the male's really negative, because sometimes they say they are and they're not. And that goes both ways, male or female. Confirm the negative partner is really negative. If you know they are, all you have to do is collect that person's ejaculate and have them as a couple. I have it happen all the time. I've had many pregnancies that way. Have that couple artificially inseminate themselves. Okay? Now, we say turkey baster method. I've never had that work. It's just there's too much volume. Okay, so what I do is I send them home with needleless 5cc syringes. Okay? And time their ovulation. Make sure they know that ovulation doesn't happen 30 days. It happens for one 24-hour period. So time their ovulation, know when that's going to happen, have them do artificial insemination themselves. I've had many successful pregnancies that way, and then there is actually really no adherent risk to the negative partner. What we know more now than we used to, and again, that goes back to where any pharmacologic product has risk, anyone. But we know because we've been giving pregnant women medication for HIV now, for almost 20 years, okay? So we know now through a body of a pregnancy registry data that we know that most of those medications really have not had high risk factors to a developing neonate, okay? Most medications are also safe to use during pregnancy. There's only one, efavirenz, which we used to say absolutely not. The highest reason you would not use it. We've gone back a little bit on that, so we don't start women who are planning pregnancies on that medication. But if she comes in and she's past her first 12 weeks, her first trimester, which is what we're worried about the most in fetotoxic events, if she's past that and she's already on efavirenz, we don't stop it if her viral load is working, because it kind of already has been done, and we know many women have shown up in the delivery room on efavirenz their whole pregnancy, and there's not been a problem. Okay, so really most meds are good, but this also is you made a great end point for me, is that this is the whole reason we do preconception counseling. Because if someone comes in, any young woman comes in, and she is saying she does, she doesn't, it doesn't matter. I'm gonna tend to put her on a regimen I know is safe, because I don't wanna have to switch her. I don't wanna have to change her. Well, actually, most of the studies around HIV, and definitely HIV around perinatal transmission or transmission in pregnancy. Almost all of those studies are done in Africa. Yeah, so almost everything I cited when we were talking about what happens with contraception, what happens with depo, what happens in pregnancy, many of them were done in sub-Saharan Africa. And that's what we always have to be really careful about, is when I'm talking about all these wonderful findings and all these wonderful treatment modalities that we have at our disposal, we have to remember that there are many more people on this globe that do not have these opportunities. So that's why, you know, you can get up and you can say, women in the US have so many other contraceptive options, so don't give anybody depo because there might be this tiny question in our mind. But that, I feel, would be irresponsible, because there are many issues on the continent of Africa where that's all they have. And a baby being born in sub-Saharan Africa has much more danger from waterborne illness. So we're not going to tell those women to not breastfeed, but what we'd like to do is get more of their viral loads suppressed. You know, babies die from malnutrition because they don't have water to mix the formula in. So are we being irresponsible when we use this very US-centric way of thinking? And I appreciate your comment, sir. Okay, so you have a copy of this. So on December 10th, 2012, ELR report came into the health department for a patient's syphilis serology requiring an evaluation. This patient is a 22-year-old African-American female. Name is Pamela Jones, who gave birth to a baby boy at a local hospital in Georgia on December 3rd, 2012.
Baltimore.
Oh, in Baltimore, not Georgia. I was incorrect. Okay. Her serology results indicated a reactive RPR and FTA. On January 15th, 2013, the health department received another ELR for the baby, which was also reactive. The health department began their investigation on both mother and baby. The DIS contacted the maternal health clinic to get a history of the patient's prenatal care. The review of the medical records indicated she was tested on June 28, 2012, with a negative syphilis, or an RPR, and HIV results. There was no other serology performed until her December 3rd delivery. So what else do you think could have happened at that maternal health clinic? Or what I should say is, what would you, in your maternal health clinics, do that might have made a difference? All right, so what do we have here? We have a 22-year-old who gave birth to a baby boy in Baltimore, okay? And her serology was she had an RPR reactive and an FTA reactive. Both of you are correct that the guidelines support that you do a test initially, which she had. She had very early, it looks like about at 3 months. So she had it early in her pregnancy, but then no one followed up. And you know, sooner than later is, and that's what the guidelines say, is if you do it somewhere around 28 weeks. I know sometimes with our patients who are dually infected, or if we're worried about someone being at great risk, because we do a follow-up HIV test also when someone's getting closer to term. So if someone was negative initially with their prenatal visit for HIV and RPR, we want to repeat an HIV even a little later than you want to do an RPR even earlier. So as Jeannie said, 3 times even in a pregnancy, and you could repeat both at delivery if you're really concerned if someone's living in a high-risk, high prevalence area. Baltimore is absolutely one of those. You know, I feel a kinship to Baltimore because Chester, where I initially was practicing, not too far up 95, Chester and Baltimore, when we were first starting our HIV clinics, we were very friendly with the folks at Hopkins HIV clinic because our epidemic started the same way. You know, you take Baltimore and make it just a little smaller, and it becomes Chester, Pennsylvania. And the reason, which I think equates to this case, is folks before Ryan White ever came on the scene or anyone ever funded anyone for HIV care, we were tracking syphilis rates to find out where epidemic centers of HIV were. And that shows where the two really connect and why I appreciate Baltimore.
What about contraception? What did you do for her at this point?
Yeah. So, all right, so any thoughts, folks, on contraception for this woman? Yeah, so obviously, you know, we haven't addressed the issues, so we don't know. She may have planned this pregnancy. We don't know that it was an unplanned pregnancy. However, somehow she got syphilis. We know she's HIV negative so far, but somehow she got syphilis. She did not want that. She did not plan for syphilis. So, I can tell you a scenario. Right, well, there it is. So where are the lesions? Do you always see them? Does anybody ever see them all the time? You know, so I mean, a perfect scenario I get, and kind of happens with HPV as well, is you'll talk to a young woman and you say, well, did you use condoms? Well, I looked at him, he didn't have anything. Okay, so, you know, I won't look ahead to the case, but you know, so are we worried that there could be, because remember, what is syphilis often? A painless lesion. Okay, it causes neurological damage. So you might have this really large lesion, you might have this little lesion, but many times people miss it because it tends to be painless. It can be hidden in cavities of the body that you never see. But we also have people who you're looking at them and you're saying they're still having sex and people are still having sex with them, and there's this huge gaping wound and you wonder, wow, how did that happen? But you know, but the opposite is also true. So she could have truly felt that she was doing everything she could do to protect herself. It doesn't mean that she had the ability to do that. Okay. So thinking that she's positive RPR, positive FTA, now has a baby that could be positive, do you think she wants or should get pregnant if we use the word should right away, or should we try to give her some effective contraception? And treatment, yes. Which I know there's going to be someone who knows much more about STD treatment than I soon, so. Okay. Well, thank you, everyone. Any other questions? So what the guidelines still say, but when we look to those recommendations, whether it's an A1 or C3, and it's all there on your slides, is you actually had some discrepancy with the panel in the last set of guidelines, saying whether someone who has a maximally suppressed viral load and all the other protocols were in place, do they need to have ACT IV during delivery? And there was some discrepancy back and forth. I can tell you that we as a practice have decided to keep giving it. It hasn't had a problem, there hasn't been a downside, we have it readily available and we do it. But we also know, and I think where, I wasn't on the panel, but I know folks who were, and I think where a lot of the give and take came back to was we have women who show up all the time and they are already delivering and the AZT never got hung and their babies aren't positive. Okay, so that's where a lot of that discussion came in. The protocol was set way back when we did not have the effective treatment that we have today, where women would show up and either not have treatment on delivery or have still detectable viral loads because our treatment and what we knew about treatment was not as effective. And we set the guidelines then, and they're looking at them now on whether we want to let some women labor without AZT. Sure. Well, thank you, everyone.